Thank you, Margaret, for the introduction. Thank you for the opportunity to talk about this topic. And so I'm so happy to talk about this. And of course, I have had my story made easier by Dr. Chen before me. So I think I'm going to stress a bit more on the radiological point of view. Guess why? And well, what we know about part solid is that those are the highest risk of being lung cancer, but there is a slight risk of bias in this definition, and I hope I can clarify it with the next slides. For instance, this one case. I think if this is the baseline screening in 2021, everybody of us could call it a positive finding, probably not 100% agreement on the part solid definition, but I think this could be agreed somewhere. But actually, this was not born as a positive finding. This was born as a very, very tiny nodule. And as we can see with these nodules, they go over from the negative to the positive definition through the time, through the years. We can follow them up for a while. And it's hard to decide when to put actually the label of a positive finding to act on. There are several data from the literature that can help us with that. It's slightly different from the solid nodules because here we have difficulty in measurement, so the volume doubling time is not really what we can rely on to be incisive and going from the active surveillance, so the conservative, non-invasive management of these cancers towards the invasive approaches. And I agree that also radiation therapy is somewhat invasive, like slightly less invasive, but somewhat, yeah. So I think the matter here is not about accuracy, because whenever you take it off, that's a cancer. So you cannot really talk about that, but we're talking about the balance of a relevant progression of those findings. So, as you might have thought while doing your lung nodule clinic or lung cancer screening, you know that you can take it out and this will be a cancer. So you're in trouble thinking about, am I doing a false negative if I call it a negative and go on? But actually the clinical definition for these kind of scenarios, I think, is more appropriate with a label of negative finding, or at least a finding that is to be managed conservatively. Because even if those are cancers, actually they're spread through the lymphatic system, they're spread out of the T parameter, is extremely limited. This paper shows the frequency of lymph node metastasis in non-solid and in subsolid and solid nodules, and you see when the frequency of lymph node metastasis in solid nodules is much larger, but as compared to the subsolid ones, these were grouped both non-solid and part solid, but also among those without lymph nodes, if you have a non-solid component, your outcome is much better as compared to those with just solid component. So that's kind of a protective factor, and this becomes confusing, right? Because those are the highest risk cancer, as we have seen from the paper of McWilliams in 2013 in New England, but actually they're kind tumors. But we can also say more about part solid nodules. So the definition of part solid is sometimes hard to apply with consistency across readers. And I think when we change the window from parenchymal to mediastinal and we see a solid component, we can all agree. But actually there are shades of part solid definition, like in this case. So you can have definitely non-solid, definitely part solid, but then you could also define high attenuation subsolid nodules like this. So if you take this green reference and you take a look at the survival curves, actually this high density, yet not really part solid, probably not for 100% of us, they still have a different perspective, a different risk trade-off. And this is something quite relevant across the literature. So this was one example from already 10 years ago, recently confirmed under other different definitions. And from my very personal point of view, well, I think the term ground glass nodule, ground glass opacity might sometimes become relatively confusing, even just for doing a Medline search. Why don't we call it them all non-solid, part solid, and solid? That would be much more straightforward, wouldn't it? But to get to the point, if you have a part solid nodule, well, yeah, you have higher risk of that nodule being a clinically relevant adenocarcinoma. Actually, we know that also the others are majorly adenocarcinoma, but with limited invasiveness across their lung parenchyma and their lymph node system around it. So we have to set thresholds. We know from older papers from the I-ELCAP that already the correlation between CT and pathology is for the 0.5 centimeters, 5 millimeter threshold, and this is probably what is conditioning also the behavior of the surgeon, or even for a very conservative surgeon like it was for the case of the BioMile trial. Once you see the more than 5 millimeter part solid nodule, actually you go invasive, because this is the prevalence of cumulative incidence of adenocarcinoma, but actually just because it was acted on that, nobody was touching the other ones with a smaller solid component. On that topic, the solid component for part solid nodule, I think most of us are measuring by absolute millimeters, which probably makes it a bit more reliable, and we're talking about reliability throughout the conference, but also the consolidation to tumor ratio is another parameter that is also used in the literature. I'm not sure how many of you use the consolidation to tumor ratio to decide the percentage of the solid component. Is anybody in the room using the consolidation to tumor ratio? Not the Chinese, yeah. I usually go with the absolute size of the solid component. But if we take a look at this figure here, so if you have a part solid nodule with total size of less than 2 centimeters, and you have less than 5 millimeter solid component, which is the less than 25%, actually, just observation, the most conservative way, we just have to call the subject for a walk to our low-dose CT suit against surgery. Well, the overall survival is pretty overlapping. And I think this topic is quite clear. The other thing, however, is that we also have to mention that when we find part solid or overall subsolid nodule over along parenchyma, not only that nodule is a potential clinically relevant cancer, but it seems that those lungs are a good ground for harvesting other cancers, or also in these subjects with subsolid nodule, you will see that also extrapulmonary malignancy is a factor. So we're talking about extremely slow-growing cancers, which apparently look like a risk factor for whatever comorbidity is going on in the body. So these are data from the MILE trial, where we're analyzing now the pooled small subsolid nodules from the mild, bio-mild, and other trials. In Italy, we will have results probably in next month. You see that the cause of death in subjects with part solid or raw subsolid nodule is actually most of the time not a cancer from the subsolid, but could be a cancer from another side, from in the lung, or extrapulmonary cancer, and of course cardiovascular disease. We have talked a lot about that. Life is not so simple when we do lung cancer screening. Yeah, we can have more than one cancer, but easy game here, right? So this is part solid, and this is probably non-solid, so this is the one to be taken off. Not so easy, actually. You go along the time, and you see that the growth dynamics are completely different. Just like when you meet a person for the first time, you might have one impression, but then it can change over time with experience and talking. So what could be the approach for this kind of management? Actually, just the conservative approach is what allows us to resect the appropriate section of the lung, leaving with a good capacity for the next intervention if it is the case. What is the metric that we can use? Well, actually, the size of these nodules, if they are smaller than 6 millimeter, well, that's already a risk factor. Well, not a diagnosis, that's a risk factor to prevent useless surgery. The other parameter, that we might want to use is something that helps us defining the growth pace. That would be the volume doubling time of the solid component. Still, we're not that accurate in that for this purpose. So more strain is still needed for making these measurements reliable. Some initial evidence from the literature is available. Yeah, we know that variability of softwares to do this task is still quite large. So we still have some step to do in this direction. And thank you for your attention.